Welcome. I'm Stephen Sandberg-Lewis, a naturopathic physician in private practice in Portland, Oregon at Hive Mind Medicine and professor at the National University of Natural Medicine. Dr. Karazian invited me to speak. He basically said, I want you to just tell people how you think and how you practice and all the details. So we decided to call it How to Think Like a Functional Gastroenterologist. That's what I consider myself, a naturopathic gastroenterologist or functional gastroenterologist. Some initial thoughts. I've been in practice for 46 years, so I have some basic tenets that I've found work for me. First of all, I really like the concept that pathophysiology is adaptive physiology. I got this idea from Dr. Dixon Tom many years ago when we co-taught gastroenterology. His thought was that let's not think of pathology as the body being stupid, doing something that's not purposeful, but let's think of it as the disease process is the body's best attempt at getting well. So I like that adaptive physiology idea. I also like to mention that when you see a patient that's complex, there are different layers of the clinical picture that I like to sometimes tease apart. So first of all, a lot of people that we see, they are taking multiple prescription medicines and natural supplements and botanicals and other treatments that may mask some of their symptoms. So when you take your history, make sure to ask, what would things be like if you weren't taking that SSRI? Or what would things be like if you weren't taking all that curcumin? Also, people, especially people that I see with digestive disorders, they tend to really limit their diet. And limited diet based on what they find is less likely to provoke their symptoms. So again, the picture may be masked by this very limited diet. Sometimes they're eating 5 foods. And then, of course, dialing down their lifestyle so that they don't do all the things they'd like to be doing. And their limited lifestyle, in addition, is going to be changing the clinical picture. So consider all those things when you take a history. Jerome Groopman, in his marvelous book, How Doctors Think, talked about some of these basic pitfalls in diagnosis. And in the introduction to my textbook, Functional Gastroenterology, I do my own little version of describing some of these things because I think they're really important. The first concept is anchoring, and that's the idea that there might be a diagnosis already in the patient's chart that you've read about from a previous workup or your own diagnosis that you've made, and the tendency to kind of latch onto that and stick to it and keep yourself from thinking in a wider way can really be limiting because complex patients have usually more than one thing going on. And if you just stick to one diagnosis, you're probably going to have trouble helping a lot of people that have a clinical picture that doesn't quite fit the standard. The second one's diagnosis momentum. And that, I think, relates to the first one. And in a way, basically, I tell my student doctors, don't believe anybody else's diagnosis. Respect them for their knowledge and the work they put into it, but look at all the data yourself. And don't trust when a patient says, they told me I didn't have celiac disease. We're going to talk more about that and how it should be properly diagnosed. Look at the data. Look at the original biopsies. Look at the original imaging and lab work and decide for yourself. Because once a diagnosis gets put into a patient's chart, it may take on a life of its own. And it just, even if it's wrong, it can become the basis of their treatment and their lack of response. The last two are confirmation bias and commission bias. So confirmation bias is if you already are thinking you know what's going on with this patient, you already know what the diagnosis is, and then you hear them say something that doesn't fit it. I like to tell my student doctors, sometimes it just goes right over your head. You don't even consider it because it doesn't fit your worldview of what's going on with this patient. And that can really steer you in the wrong direction. The commission bias is, on the other hand, Dr. Linda Lewis is famous for saying, don't just do something, stand there. Because certainly when, especially in acute situations, there's a feeling like you really have to do something, even if it's not well thought out, just do something. But sometimes if you have the ability and you're not in an emergency situation, step back and take another look at it before you just do something for doing's sake, so to speak. I'll let you know a little bit about the questionnaire that I give my patients and my history and exam. Some of the important questions that I consider are, the first one, any incidences in which your brain was shaken, and approximate age. If you just say to a patient, have you ever had a traumatic brain injury or a head injury? That will greatly limit your ability to detect how many traumatic brain injuries they've had. Because traumatic brain injury tends to get minimized in medicine, but I think we're starting to get a little better at it. So I say, head injury, whiplash injury, didn't even hit your head, broke your nose. Most patients, they don't even realize if they broke their nose, they shook their brain enough to have a traumatic brain injury. Broken tailbone because the shock wave goes up through the spine and into the skull. Blacking out and falling down. The patient blacked out. They might not realize or think about that part when they were unconscious and their head hit the ground. And blast injuries as well. Patients that are veterans who were in the sandbox wars and had their Humvees blown up or were near improvised explosion. That shock wave goes through the brain and can do a lot of damage, even though there was no trauma to the head directly. And heading the ball in soccer. Of course, I didn't put football in there. I think that's clear cut, football injuries, but heading the ball in soccer, that's also an object suddenly hitting the skull and bouncing off, and the person doing a little work with their neck to push it back up. That's really, in many cases, a cause of chronic traumatic encephalopathy. So that's one really important question to me, because brain injuries really affect the digestive tract. Another question about, of course, how they were born, whether they were breastfed, whether there were any exposures prenatally, and whether they were in the NICU. If you know that a patient was low birth weight, born at 3 pounds or 4 pounds, that is going to travel through their entire life with them and affect their risks for certain diseases. Have you worked or lived in a water damaged building, or lived in a moldy place, or worked in a moldy place? Mold illness is a big factor for a lot of patients. Tick bite and Lyme and co-infections, just like to ask about that. That can be important. It can be ignored sometimes as an underlying trigger or cause for a number of their conditions, including in the case of Lyme and co-infections, and Bartonella in particular can be related to intestinal methanogen overgrowth, which causes a lot of digestive problems. We ask if they're an outdoor person just because if they don't know that they had a tick bite, if they've been deer hunting or spent a lot of time in the wild and tall grasses, they certainly could have had tick bites and not known it, since ticks can settle in the scalp and not even be seen before they fall off. I would like to ask about any history of eating disorders. Of course, you can have one without being diagnosed with one, but at least ask if they've been diagnosed with an eating disorder, because that's going to affect the way we manage their diet or stay away from managing their diet or get help with that. Like to ask about their flexibility, or whether they ever consider themselves to be double jointed. We're going to talk more about hypermobility syndrome, but it's a major cause of all kinds of digestive problems, often not screened for and completely missed. So you can ask questions like, were you ever able to do the splits or do tricks for your friends, like putting your foot behind your neck, things like that. And then, of course, food poisoning. By the way, I have put in some URLs for blog posts that I've created that are on my website, Hive Mind Medicine. There's one, a little more technical, I believe, for doctors, that is on food poisoning. I think it's called Food Poisoning, the Gift That Keeps On Giving, because food poisoning is a known risk factor for triggering or bringing out a latent Crohn's disease, latent post-infectious IBS, and also celiac disease in patients that previously were not symptomatic. So good to ask in a few ways. Ask the patient food poisoning, traveler's diarrhea, gastritis, or gastroenteritis, because they may have heard what they had was one thing in a different terminology. So try not to limit it. Some patients won't remember that they had food poisoning, but maybe it was so bad they just blocked out that whole thing. But good to know about. We'll talk about some tests that are specific for post-infectious IBS to follow up with those. I like to ask about whether they have any reactions to metals, because nickel sensitivity is not uncommon. And if a patient, for instance, reacts to nickel in earrings and they get erythema, edema, itching, oozing, just from contact there are foods and cookware that contain nickel. And if they are ingesting those things, that may be causing a similar reaction in their gut. So we need to know about that. And then, of course, asking about their diet. On medication history, all medications can be important, but I especially, because I'm interested in the microbiome and changes in it and changes in motility, I'm going to ask about history of antibiotics, proton pump inhibitors, H2 receptor antagonists, not quite as damaging to the microbiome, but I want to know about that too. Antidiarrheal medications, especially anticholinergics that slow down the gut. Muscle relaxants, which can slow down the gut. And of course, narcotics, which really can slow down the gut and affect the various sphincters throughout the gut in a negative way. Steroids, because they suppress the immune system in the gut and have multiple effects on digestion and absorption. And then, of course, the nonsteroidal anti-inflammatory drugs